is all about parasitology and Entamoeba histolytica. Now, before discussing all of this, let us explore first what are the facts about Entamoeba histolytica that will definitely blow our minds. So the first is human can be a host to 100 different types of parasites. Entamoeba histolytica is a parasitic protozoan part of the genus Entamoeba. It infects mainly humans and other primates. Did you know that Entamoeba histolytica infects an estimated 500 million people per year, causes liver abscess and colitis in 50 million, and results in death of an estimated 40,000 to 100,000 individuals annually? It is also a worldwide distributed pathogen, and also it is the second leading cause of the parasitic death. Infections due to Entamoeba histolytica are more common in tropical and subtropical areas such as Mexico, South and West Africa, West South America, and also the South Asia.
Parasites are living organisms which depend on a living host for their nourishment and survival. They multiply or undergo development in the host. The term parasite is usually applied to protozoa and helminths.
Now, let's talk about parasitology. So, what is parasitology? What is the history of parasitology? And who contributed the history of parasitology? Generally speaking, parasitology is the branch of microbiology that is concerned with the study of parasites. In the process, it gives focus to various characteristics of the parasites, the type of host they infect or affect, and the relationship between the two. Medical parasitology deals with the parasites which cause human infections and diseases they produce. The history of parasitology is scattered among a number of other disciplines, especially zoology. Many highly evolved parasites remain essentially unknown or misunderstood until the advent of the microscope in the mid-17th century. A pioneer in the field of intestinal parasitology was the mid-19th century Belgian biologist P.G. van Beneden, who unveiled the life history of tapeworms and many other groups. The scientist that contributed in the history of parasitology, the pioneer Dutch microscopist Anthony van Leeuwenhoek of Holland in 1681, first introduced the single-lens microscope and observed Giardia in his own stools. Louis Pasteur in 1870 first published the scientific study on a protozoal disease leading to its control and prevention during investigation of an epidemic silkworm disease in South Europe. A seminal discovery was made in 1878 by Patrick Manson about the role of mosquitoes in filariasis. Afterwards, Laveran in Algeria discovered the malaria parasite in 1880, and Ronald Rose in Secunderabad and Kalpuna in India showed its transmission by mosquitoes in 1897.
Classification and life cycle of parasites. Parasites of medical significance are divided into two main categories that include the single-celled parasites or the protozoa and the multicellular metazoa or what we call the helminths. Protozoa parasites include malaria parasites, ciliates and flagellates, and also the amoeba. These are single-celled organisms that generally live inside the body of the host. They obtain nutrition from the host depending on where they are located. Parasites are able to multiply and increase in number. This ensures their survival as they can be transmitted from one host to another. Helminths are multicellular parasites that tend to be bilaterally symmetrical. They include the members of cystodes such as tapeworm, trematodes such as flukes, and nematodes such as roundworm. Like protozoa, however, helminths are endoparasites that are generally found in the gastrointestinal tract. Parasites can also be classified as ectoparasites and endoparasites. In ectoparasites, they inhabit only the body surface of the host without penetrating the tissue. In endoparasites, they live within the body of the host and cause infection.
The modes of transmission. The first mode of transmission is the oral transmission. This is the most common method of transmission through the oral route by contaminated food, water, soiled fingers, and deformities. The second mode of transmission is the skin transmission. Hookworm infection is acquired when the larvae enter the skin of persons walking barefooted on contaminated soil. Vector transmission. Many parasitic diseases are transmitted by insect bite. Direct transmission. Parasitic infection may be transmitted by person-to-person contact in some cases. Vertical transmission. Mother-to-fetus transmission may take place in malaria and toxoplasmosis. Iatrogenic transmission. It is seen in the case of transfusion malaria and toxoplasmosis after organ transplantation.
And right now, we will tackle about the amoebae. The term amoeba refers to a simple eukaryotic organism that move in a characteristic crawling fashion. However, a comparison of the genetic content of the various amoebae that shows that these organisms are not necessarily close related. Amoebae have been known to cause a range of human diseases. Amoebiasis or amoebic dysentery is an infection caused by Entamoeba histolytica, a human intestinal parasite. According to the National Institute of Health, Entamoeba histolytica can invade the colon wall and cause colitis, or it can cause severe diarrhea or dysentery. Though the disease can occur anywhere in the world, it is most predominant in tropical regions that have substandard sanitation and crowded conditions.
Did you know that human infections of the parasite is not a recent phenomenon? The earliest record of symptoms of the disease bloody mucus diarrhea was from the Sanskrit document Brigo Samhita, written at around 1000 BC. Assyrian and Babylonian also have references to the diseases with descriptions of the blood in the feces, thus suggesting that amoebiasis occurred in the Tigris-Euphrates basin before the 6th century BC. Around 16th century, amoebiasis became more widespread in the developed world, mostly due to the growth of European colonies and increased world trade. Considering the small size, protozoans were difficult to identify before the invention of the microscope in 17th century. The causal agent Entamoeba histolytica was discovered in Russia in 1873 by Frederick Lush. His early observation came from a young farmer who had been suffering from chronic dysentery. In his diagnosis, Lush found large numbers of amoeba in his feces and associated the amoebas to be the cause of the dysentery.
So the following topic is all about the stages and reproduction. So the morphology of the Entamoeba histolytica occurs in three forms. So the first one is trophozoite, second is the persist, and lastly is the cyst. So the first form that we are going to discuss is the trophozoite. So trophozoite is a vegetative or growing stage of the parasite, and also it is the only form present in tissues. It is irregular in shape and varies in size from 12 to 60 micrometer and average being 20 micrometer. It is large and actively moral and freshly passed dysenteric stool, which smaller in convalescence and carrier. So the next stage is all about the persisting stage. So in this stage, trophozoites undergo encystment in the intestinal lumen. Encystment does not occur in the tissues nor in the feces outside the body. Before encystment, the trophozoite extrudes its food vacuole and becomes round or oval about 10 to 20 micrometer in size. It contains a large glycogen vacuole and two chromatid bars. It then secretes a highly retractile cyst wall around it and becomes a cyst. As the cyst matures, the glycogen mass and chromatid bars disappear and the nucleus undergoes two successive mitotic divisions to form 2 and then 4 nuclei. The mature cyst is thus quadrinucleate. The cyst wall is highly refractile membrane, which makes it highly resistant to gastric juice and unfavorable environmental conditions. So the next topic is all about the reproduction. So reproduction occurs in 3 stages. The first stage is excistation. So this process of transformation of cysts to trophozoites during excistation and quadrinucleate cyst gives rise to 8 amoebilla, each one of which is being capable of developing into a trophozoite. So the second stage is the encystation. So this process of transformation of trophozoite to cyst occurs inside the lumen of the intestine of an infected individual. So the last stage is the multiplication. So this occurs only in the trophozoite forms of the Entamoeba Histolytica. Growing and multiplication takes place inside the tissue. Reproduction occurs only by simple binary fission.
Amoebiasis is an infection of the intestines. It caused by the microscopic parasite Entamoeba histolytica. A histolytica can live in the large intestine without causing damage to the intestine. In some cases, it invades the colon wall, causing colitis, acute dysentery, or long-term diarrhea. The infection can also spread through the bloodstream to the liver. In rare cases, it spread of the lungs, brain, or the other organs. The parasite may spread through food or water contaminated with stools, through fertilizer made of human waste, from person to person, particularly by the contact with the mouth or rectal area of an infected person.
Let's talk about hemobiasis. So, what is hemobiasis? What is the cause of hemobiasis? Intestinal hemobiasis is caused by the protozoan Entamoeba histolytica. Most infection is asymptomatic. Clinical manifestations include amoebic dysentery and extraintestinal disease. They cause disease only when they invade the intestinal tissue. 10% of symptomatic and 90% of asymptomatic. Not all strains of Entamoeba histolytica are pathogenic or invasive. In extraintestinal hemobiasis, the hepatic hemobiasis is the most common extraintestinal hemobiasis. The history of amoebic dysentery is absent in more than 50% cases. Several patients with amoebic colitis develop an enlarged tender liver without detectable impairment of liver function or fever. This acute hepatic involvement may be due to the repeated invasion by amoeba from an active colonic infection or to toxic substances from the colon reaching the liver. In about 5 to 10% of persons with intestinal hemobiasis, liver abscesses may ensue. The center of the abscess contains thick chocolate brown pus, which is liquefied necrotic liver tissue. At the periphery, there is almost normal liver tissue, which contains invading amoeba. Liver abscess may be multiple solitary. This usually located on right lobe of liver. Jaundice develops only when lesions are multiple or when depressed on the biliary tract. Incidence of liver abscess is less common in women and rare in children under the age of 10. Pulmonary hemobiasis may occur by direct hematogenous spread from colon bypassing the liver, but it most often follows extension of hepatic abscess through the diaphragm. Hepatobronchial fistula usually results with expectoration of chocolate brown sputum. Patients present with severe pleuritic chest pain, dyspnea, non-productive cough. Metastatic hemobiasis is the involvement of distant organs by hematogenous spread and through lymphatics. They are absent in kidney, brain, spleen, and adrenals. It spread to brain that leads to severe destruction of brain tissues and fats. Cutaneous hemobiasis occurs by direct extension around anus, colostomy site, or discharging sinuses from amoebic abscess. Extensive glandular destruction of the skin occurs. The lesion may be mistaken for condyloma or epithelioma. Genitourinary hemobiasis. Penile hemobiasis repose and glands are affected, acquired through anal intercourse. In females' vulva, vagina, or cervix by spread from perineum, destructive ulcerative lesions resemble carcinoma.